video, we're going to discuss the hormones involved in the hypothalamus-pituitary-adrenal axis, or the HPA axis, and their regulation, specifically focusing on those negative feedback loops again. So another goal of this video is also to introduce you to the different agents available that actually supplement the HPA axis that are needed in the setting of adrenal insufficiency. Specifically, we're going to be focusing on our glucocorticoids, which I'll abbreviate as GC, and we're going to mention our mineralocorticoids, and I'll abbreviate those as MC, and how their mechanisms affect this tightly regulated axis. And from this discussion, I hope that you can determine which agents may be of benefit to your IQ patient this week. Now we're going to begin our cascade up here with our hypothalamus, where the corticotropin releasing hormone, or CRH, is released to then act upon the anterior pituitary, triggering the release of adrenocorticotropic hormone, or ACTH. So ACTH is going to travel to act upon our adrenal glands to then trigger the release of cortisol. And cortisol is one of our steroid hormones. Most people think of this as our stress response hormone, but it plays many, many functions in the body. But we'll talk about a few specifically, so definitely stress response. We also have immune response and function, as well as metabolism. Cortisol is synthesized in the zona fasciculata layer of the adrenal cortex, and when secreted, cortisol is going to travel in the systemic circulation, mostly bound to cortisol or corticosteroid binding globulin, which I'm showing you down here, abbreviated as CBG. This is also known as transcortin. And it also might bind some other plasma proteins and travel with those as well. But any free hormone is what is actually going to be active and can enter those target tissues to bind to our glucocorticoid receptor, which remember is going to be our focus in this video. And eventually that is going to translocate to the nucleus, bind the appropriate response elements, and promote downstream gene expression. And while all of this is going on, cortisol is still providing negative feedback at the level of the hypothalamus and the pituitary, very similar to the more simple negative feedback loops we discussed with thyroid hormone, for example, versus for estrogen and progesterone, which, if you remember, is a little bit more complicated. But this ensures that the appropriate amount of cortisol is released, and we have, again, sort of that Goldilocks effect. Now, we are specifically focusing on the glucocorticoids and the downstream effects here. However, all of the glucocorticoids that we are going to discuss do have varying degrees of mineralocorticoid activity, where mineralocorticoids are also steroid hormones produced in a different region of the adrenal cortex that are important for fluid and electrolyte balance. And the main mineralocorticoid is going to be aldosterone. And aldosterone and its main function in promoting fluid and electrolyte balance is going to be more of a focus in block 4. But I think it's important for you to just have a basic understanding of mineralocorticoids next to our glucocorticoids. And this will be important for you to appreciate as you think about how to correct adrenal insufficiencies that are due to primary versus central causes, and what agents available can you use to recapitulate normal physiology. So now that we have completed this sort of simplified overview of the HPA axis, let's go over some of the therapeutics that target this axis or supplement it on our next slide. As I said, we're going to focus on our corticosteroids, specifically the ones that are glucocorticosteroids. And this will be an incredibly important video because these agents are going to be presented in different contexts in every single block and are really commonly used. So you will see a list of the most common glucocorticosteroids on the next slide, but these include things like hydrocortisone, which is particularly useful in the context of adrenal insufficiency, so we'll talk about that one, as well as cortisone, prednisone, and dexamethasone, etc. And these agents will all mimic cortisol. So that means we are essentially supplementing or replacing the cortisol or adding in addition to, so that it will move through the body similarly as cortisol would, eventually binding to the glucocorticoid receptors, and that's going to translocate to the nucleus, to the appropriate response elements, and to those promoters of target genes. And this is either going to inhibit transcription or promote the expression of genes needed in that particular target tissue. And there are so many target tissues in the body that we will not go over each and every effect, but you will get some examples when we actually go over the long list of adverse drug reactions for these particular agents. As an added bonus, the glucocorticoid-bound receptor can also recruit HDAC to help modulate gene expression as well through deacetylation of histones, causing additional gene repression. So now in adrenal insufficiency, we are obviously trying to replace what is missing. So our dosing strategy of our glucocorticoids in this particular context needs to provide a total daily dose that is very close to physiologic release in order to avoid the adverse drug reactions and the side effects that commonly come with excessive glucocorticoid use, which we'll discuss in a minute. And we also want to make sure we are simulating or mimicking the normal pattern of cortisol secretion with higher levels in the morning that gradually decline throughout the day to almost none by late evening. So in this case, we want to use a glucocorticoid that most similarly mimics cortisol, or our endogenous molecule, which we will get into more on the next slide, but that agent is going to be hydrocortisone. But I do just want to point out that we use these agents a lot for many immune-mediated disorders like autoimmune diseases. And for these, we're actually going to use much stronger and more potent glucocorticoids at much higher doses to get effects beyond the usual normal physiologic effects, because there is an imbalance that the normal cortisol release in these conditions does not keep in check. And when we do have to go this route, unfortunately, there can be a much higher risk for adverse drug reactions or more extreme adverse drug reactions. So when we do have to use our glucocorticoids for these purposes, like in autoimmune diseases, and we need to go higher and stronger, we want to try and use the lowest dose for the shortest duration possible that still allows us to get that effect so that we can minimize these adverse drug reactions as much as possible. All right, so now let's get into those adverse drug reactions. So as you might guess from talking about our autoimmune diseases, these are going to be immunosuppressants. And that's going to come with a risk of infection. They're also going to cause a lot of different imbalances across normal cortisol functions. So things that can happen can be the retention of salt in water, causing edema and hypertension. There can also be peptic ulcer disease from increased levels of gastric acid production. There can also be adrenal suppression because we're giving those high doses and they can feed into these negative feedback loops. We can also have hyperglycemia, dyslipidemia from changes in metabolism. We can also have psychosis, glaucoma, and cataracts, as well as poor wound healing. And most of this is just from altering sort of normal cortisol functions and regulations and sort of overpowering the system. So again, many concerning ADRs, which is why we want to, again, use the lowest dose for as short as possible. But obviously, in adrenal insufficiency, we are probably not going to be using these super high doses like we would with these conditions. And we're not using as potent of agents, but they might be needed chronically depending upon the cause of the adrenal insufficiency. So it's still good to keep these in mind. So let's talk about some important pharmacologic considerations that we can use to sort of compare the agents within this class and help differentiate them. So moving to our next slide. And here is our summary slide and a very important comparison chart of some of the most commonly used steroids, where most are going to be our glucocorticosteroids. And this last one, fludrocortisone, this one is used when mineralocorticoid supplementation is needed. So again, thinking about adrenal insufficiency and when this supplementation is going to be needed and when it probably won't be. And in this chart, we are comparing a few different things. So first, anything with this star is going to be available both orally or PO, as well as IV. And anything without, we are only taking it orally, so cortisone, for example. And the nice thing is, when you give these agents with the star orally, almost all of it, if not all of it, actually is fully absorbed. And we will talk about this as bioavailability, which is abbreviated as F. And this is just the amount of drug given that makes it into the systemic circulation. And anything IV is 100% bioavailable, which makes sense, right? Because you're putting that drug straight into the systemic circulation. But this is important because it makes it really easy for patients to be switched from IV to PO and vice versa if needed for discharge or being admitted, etc. Now, I just wanted to introduce this here because we will revisit it in block 4. Now, here we are also comparing the equivalent glucocorticoid dose, which deals with the drug's pharmacodynamics and at which dose do the glucocorticoids all elicit the same glucocorticoid effect. So in other words, what dose of dexamethasone, for example, down here, is needed to achieve the same effect as hydrocortisone at 20 milligrams. So this comes in handy when you need to switch between different agents for whatever reason. And it tells you which are the most potent, and the lower the dose needed to elicit the effect, the more potent it is. Like with dexamethasone down here, for example. So sometimes potency will be shown as this sort of milligram comparison I'm showing you here, or it might be shown like I have in this next column here, where it is relative potency to the prototype, which in this case is going to be hydrocortisone. So here we're looking at mineralocorticoid potency. And we're going to start with cortisone and give 10 milligrams. But then what we're also going to do is we're going to give 10 milligrams of all of these agents and see what effect we get. And then we're going to compare that back to the effect we actually get with our prototypical agent being hydrocortisone. And this would give us a relative potency. Again, here we're talking about mineralocorticoid potency. So it makes sense that fludrocortisone is 150 times more potent than hydrocortisone, which is typically thought of for its glucocorticoid activity. So again, just trying to introduce the different ways you might see potency presented for glucocorticoids, but this is also going to apply to other agents in future blocks, and we will come back to this idea of potency. Now, we also need to compare these agents with regard to pharmacokinetics. Before, we've been talking about pharmacodynamics. Now we're going to talk kinetics. And specifically, we're going to talk about half-life, which helps us inform the duration of action of the drug, which can be categorized as either short, intermediate, or long-acting. And as you might imagine, for someone with adrenal insufficiency, you want to mimic the normal cortisol release. So the short-acting ones are going to be helpful because you can titrate accordingly and dose multiple times a day across the day to mimic that pattern that usually occurs. So this would be ideal, but again, if we're dosing multiple times a day, there might be an adherence issue, so you may need to go to one of the intermediate agents. But then if we're talking about those sort of autoimmune and immune-mediated flares or diseases, then you'd want to move further down here to these more intermediate and long-acting agents to provide all-day coverage and that immunosuppression. So again, I just want to mention these. I realize that these details are beyond what you need to know at this point in the curriculum, but In future blocks and in clinical practice, we'll have to revisit this, and eventually you're going to have to select glucocorticoids and do conversions and switch from oral to IV. So introducing these comparisons now will help as you continue to revisit these agents in each block. So I hope this video has provided you with a solid foundation for understanding the HPA axis, this concept of glucocorticoids versus mineralocorticoids, and the class of agents available that can be used to supplement the cortisol that is missing or that is being produced and it's just insufficient for the particular disease in question. So we also introduced some key pharmacologic considerations that vary across the agents that fall in the glucocorticoid class and the mineralocorticoid fludrocortisone, and how to think about bioavailability, equivalent doses, potency, and duration of action to help you choose the agent that's most likely to align with the needs of your patients.